Thank you, Dio. Oh,
Yeah.
so much information. Can you hear me? Yeah. Thank you very much. That was amazing to both. Okay, so I could have next slide, please. I'm sad that I need to talk to you after such incredibly full presentations because I feel like your brains must be absolutely squished. But let's do what we can. Maybe take a breath, look out the window. Okay, so this picture here, I thought that would be quite nice for you to have a moment to focus on. This is what it feels like in someone's head, perhaps when they've got a delirium, somewhat disorganized. Okay, next slide, please. Okay, so today I'm really hoping that by talking about Mrs. N with you, I'm going to refresh your memory about delirium, hopefully prompt you to notice things, and you can actually be more confident in recognizing when maybe somebody has a delirium. I'd like you to talk about delirium, think about delirium, and just tell the world because it's highly preventable. Okay, next slide, please. Right, so Mrs. N, when I went in to see her for the first time, she was fast-tracked home, so I believe they thought she was going to die within 2 weeks or so, and this was 3 months later. She was still going strong, sleeping all day in the chair, frightened to get into the bed. She had deteriorating pressure areas. She had infected lesions all over her body. For the last 3 weeks, she'd had frequency and urgency of urine, sleeping during the day, awake all night. So her family were on their knees trying to care for her because obviously they both had jobs as well. She had a lot of pain in her hips and knees, and she really wasn't very interested in doing anything other than drowsing throughout the 24 hours. Next slide, please. I wonder if any of you recognise any of your patients in Mrs. N. Anyway, for our next slide, I thought it would be quite nice to just see the official definition of delirium, things to focus on: disturbance of attention and orientation. So who are you? Who am I? Where am I? And it develops within a short period of time. Those are the key words, and it fluctuates. It can also change your behavior and it can change your emotion. Next slide, please. And really lovely to see here, it's a disturbance of the sleep-wake cycle. So reduced arousal, so someone who might be sleeping all day, not sleeping at all, or sleeping in the day and awake at night. You can see at the bottom the 3 types of delirium. So the hyperactive one is the one where you can see someone who's sleeping all day, and the agitated one, you may have all seen someone who's wandering around the ward, might be trying to hit people, might be screaming, walking all day, and then you get people obviously who present with both. Now, I wonder if you think to yourself, which one of those patients gets more attention? And you'd be right if you thought agitated. I'm smiling, but actually the downside of it is if you have a hypoactive delirium, those people, patients are have much higher mortality rates. It's very easy to leave them, especially if you're a busy therapist. Oh, she's asleep, I'll come back later. And of course, later doesn't happen. And that happens again and again. Next slide, please. So how common is delirium? Well, it's more common in older cancer patients, equal between males and females. It's very common where someone has a pre-existing cognitive impairment. So clearly, we've heard that 77% of patients with cancer have a cognitive impairment. So automatically, you can see that delirium is huge. And here you can see nearly 50% of cancer patients have a delirium. I've put in here that 40% are reversible, and I'll come to that in a bit, but that's quite exciting. And that's really part of the reason why I'm talking to you today. And the other figure that's quite interesting is that delirium is also 40% preventable. So just think what we can do. Why is it important? Oh, I'll just address final days of life. So there is some research that's thinking about delirium might actually be a part of the dying process. So it's likely not reversible. Why is delirium important? it's important because you have much higher mortality rates once you have a delirium. Once people have had a delirium, their cognitive scoring goes down. They're much more dependent physically, more likely to go into care. And then they also are more likely to get delirium again. And obviously, several or repeated deliriums can actually lead to dementia. Next slide, please. Okay, I thought this might be quite helpful. So that maybe it can trigger you. So when you go in to see someone and, the nurse says, oh, she was so confused earlier, and you go in and you think, no, she's fine. What are they talking about? Maybe they didn't do a great assessment. Or the relative talk about he's sleeping all day. When someone mentions that actually their relative is, and they all say in a hushed voice, they're actually talking to someone, but there's no one there. So, let those things kind of trigger you with the fluctuation, with the sleeping, hallucinations. They're actually, quite common. Next slide, please. Okay, so the NICE guidelines are really clear about delirium. What they really want us to do is, first of all, identify if someone's at increased risk. So those who have an increased risk of delirium are the over 65s, which is huge. And then, of course, you have anyone with a severe illness, and that's where cancer comes in, a new fracture, surgery. So the first thing is, if you have anyone, and you probably all have those because you're here on the Cancer Community Care Practice, anyone with cancer is already at an increased risk of delirium. So once you have recognised that someone has an increased risk of delirium, what we need to do is carry out interventions to prevent delirium. So these are the things that can cause delirium. So you've got untreated infections. There's many reasons why a person with cancer might have infections, but obviously if they're neutropenic, then you've got opportunistic infections. Lots of people have poorly treated pain, perhaps from the chemo or the tumor. Vicky talked a lot about fatigue, and if people are sleeping a lot during the day because they got a poor nighttime sleep, then eventually that can lead to an altered wake sleep cycle. Obviously, lots of people with cancer have all the drugs that we talked about for pain medication. As soon as you have those drugs, they can start having an effect on the bowels. Then you can see the other things. Sensory impairment is quite an important one. So impaired vision or hearing. Simply not having glasses can actually cause someone to develop a delirium. And as Dia was talking about dementia, once someone has a dementia, then they're immediately at higher risk of delirium. There's something called incident delirium, which is a very healthy person, obviously over 65 or with severe illness, going into hospital, develops a delirium. And that's a cause for further research, which they don't really know why yet. Next slide, please. I thought this was quite interesting because it shows you the disorganization that happens. So the picture of the brain on the left, this is the one in the center, that's the thought, and then the line represents the action. And then as you move slowly to the right, you can see that the thought is not going direct to the action, and by the end, the brain on the right, you can see that it's taking a multiple circuitous route to get to the action. Next slide, please. Now, I'd love to talk to you more about why delirium happens, but unfortunately, that's not going to happen today because of time. So next slide, please. I thought this was helpful because a lot of people wonder, this includes carers, is it dementia? And if you look where the blue stars, the highly different things about delirium from dementia is that delirium fluctuates. So you can see that sometimes, like I spoke about before, people might have times when they're absolutely lucid and responding appropriately, and then they can go very, very confused or disorientated in time. The other thing about delirium is that it happens, the onset is acute, so it can happen within 2 days, whereas with a dementia, it's happening over, 6 months, a year, 18 months. So I think it's really helpful to know that when you go in and speak to a next of kin and they're so worried that it's a dementia, you can actually say, well, the likelihood is it was an acute onset, it's happened quickly, they seem to have an infection, it may well be a delirium. And I just want to draw your attention to the attention one. So that's the main one. The attention is impaired. And you've got sleep-wake cycle as well. Next slide, please. This screening tool, I don't know if you've heard of it. It's now been recommended by the NICE guidelines for use potentially in the community, but definitely in hospital. If someone's in ICU, they want you to use the ICU CAM. And what's lovely about it is you can see it's been validated using studies involving over 5,000 people. It's really quick. And next slide, please. I have a gift for you. Next slide, please. This is actually available on an app. Now, I wish I could show you, but I can't because it'll all blur out. But you can get it on your phones. Just search up 4AT. And that means that you can actually do a screening assessment on your patient. You don't have to go and find the paperwork, remember the questions. It's beautiful. So you can see the first question is, how alert is the person? It's ever so easy to score. If they seem fine or they're a little bit sleepy when you get there, but they're after 10 seconds they're okay, then that's absolutely normal. Now, Mrs. N was clearly abnormal because she was drowsy, so she'll score a 4. And the second one's about memory. So what's your age, date of birth, place, name of the hospital, where you are now, and what's the year. Now, it's not to worry because all of us think, oh, you could get that wrong very easily, but the maximum that's scored is only 2 points if they can't manage any of those. And that doesn't indicate a delirium. So then the third question is attention. Now, I love this test. It's basically asking the patient to do months of the year backwards, starting from December. Now, I hear you say that's really hard, and it is, but actually, if I asked you to do it now, you can do it. It just takes time, and that's exactly what this question is doing. It's asking you to run through it, to have to maintain the task. So you have to have the attention to hold the task in your mind. Then you have to review what you're supposed to do. Then you have to manipulate the data, and then you have to give the answer. So it's actually quite a complex task. And sometimes you get people say December, January. No, the month before December. December, November, December, and then you stop. It's really clear it isn't worth continuing. If you've had 2 false starts, they are not going to manage it. Okay, so Mrs. N, she managed 3 months, so she scored a +1. And then if someone is quite drowsy, or they've got hallucinations, or they're sleeping a lot, then it's an automatic +4. And this lovely little app, you just press calculate and it gives you the results. So Mrs. N has got a possible delirium, and she may have an underlying cognitive impairment. And I didn't mention that she actually did have an underlying delirium. But before she was discharged, she was walking around, getting on and off the bed, watching TV, enjoying her days. So it was a huge change in her. Next slide, please. Right, now this is a long word, non-pharmacological interventions, and I hope if you look at it, it's actually really simple. It just means no drugs please. Okay, so once you've identified someone with a higher risk of delirium, then there's some simple things you can do to make sure they don't develop, or to reduce the risk of them developing it. So 40% you can affect this. So someone who has a higher risk, you need to make sure their bowels are open every day, and that their bladder, that they're not dehydrated. try and make sure they have a daily routine where they're sleeping during the day. No, wrong one. Sleeping at night and awake during the day. Make sure they've always got their glasses and hearing aids. Give them something to do. So Mrs. N was stuck in her room with just the wall, and tell me, if I was stuck in my room with just the wall, I would be asleep all day. So you need, you need to be engaged. Opioids can also have an impact on the onset of delirium, so make sure that they can be eliminated. Regular reorientation. So you know how we go in and we say, what's the date? What year is it? Don't do that. You say to them, it's September the 13th. My name is Tanya. I'm just checking how you are today, and your daughter's coming later. So reorientate, remind them who you are, and that can really help with the prevention, and make sure they can sleep at night time as well. Next slide, please. So, and the next slide, please. So Mrs. N, now I'd like you to think, these are the things. So she had a new functional deterioration. So that should be a tick. So she had a change in her function. She had pain from her pressure areas. She had pain from the lesions on her arms and legs. She had hip and knee pain. She was only on paracetamol once a day. So she had a lot of pain. And those 3 types, you know, even one of those poorly managed pain would be enough to start off a delirium. And then she had a urine infection. She'd had one for 3 weeks, untreated. And there's a study that shows that every day of untreated infection increases the mortality rate by 4%. And she was also sleeping during the day. So she has so many reasons why she had a delirium. Next slide, please. Okay, so when you have someone in mind, remember that their attention is impaired. So if you speak to them, don't quite bark it out, but speak in short sentences. No long-windedness like me today. Just, how are you? Let's get off the bed. You need to drink this, those kind of things. The infections need to be treated. You need to reassure both the carers and the patient. There's a lot of anxiety and even PTSD related to a delirium, because people don't understand what's happening to them in their lucid moments. They don't understand what's happening to them, and the family are very, very frightened they're developing a dementia. So it's really important to engage everybody. As you can see down here, these are the things what you need to do. Next slide, please. I really want you to walk away thinking, I'm going to tell people about what a delirium might look like. Tell them what to look for, and then what they can do if their relative is at a high risk. All those non-pharmacological interventions, those things are incredibly important, and they can absolutely make a difference. The evidence shows. There is a case for opioids if someone's very agitated, but they're used at the smallest possible dose. There isn't really good evidence for it. So that's a case that's still being researched. Use the screening tool, and just if someone's different in any way, just think delirium. I invite you to do that. It will change everything. Next slide. I just wanted to put this in. It's quite interesting. It shows you that actually anxiety before an operation in cancer patients predicts whether they have a delirium. So again, there's so much we can do. We can tell people they need to prepare for the operation in any way that's possible. They might need to visit. They might need to, there is again evidence that melatonin before operations can help, or a mild sedative. We need to try to look after people and prevent that delirium. Next slide, please. And there's some references. Next slide, please. There you go. Thank you very much for listening.